Hello, everyone, and good evening. My name is Chris Schroeder, and I am your moderator for this evening. Tonight, or late this afternoon, or whatever time it is where you are, I will be moderating the ASRA Pain Medicine Hot Topics webinar presentation on where do we go from here, regional anesthesia expansion considerations in academia and private practice. So I'm really excited for this topic and the panel of accomplished regional anesthesia and acute pain management specialists that we have assembled to speak with all of you here tonight. My hope really is that we can make this a conversation, that we can hear from all of you, that we can answer the questions that you have, and that this forum is an opportunity for you to interact with this amazing panel of presenters. And so all along the way, this is going to be open for questions. You know, if you've been to our Hot Topics webinars in the past, this will be a little bit different. You know, we're not going to have the formal presentations followed by questions all along the way. If you have a question, please go ahead, type it into that small Q&A text box at the bottom of the screen. And then when you're finished, click send, and then we'll try to address those questions as we go and make it as valuable for you as we can. Now, in lieu of me introducing each one of these panelists, my hope is that each one of them could introduce themselves, kind of talk about the practice in which they work, and then maybe give an example of a recent win, you know, some opportunity that they saw, you know, where they were able to introduce regional anesthesia into their practice and, you know, maybe some of the challenges that they were able to overcome. All of our screens are probably different, but immediately to my right is Dr. Kim. And so I'll go ahead and have him go first.
Sure. So I've been at HSS for about 15 years, and it's a primarily orthopedic hospital. And for the past few years, we expanded quite a bit. You know, we expanded to a lot of the ambulatory centers. One down in Florida, one down in, well, we're opening one in New Jersey. We're going to open another one in Long Island, and we opened two in the city as well. And I happened to be the one that opened the one in the West Side. I was the West Side director for about 4 years. So I got to see, you know, the changes that need to be done in order to incorporate regional to make sure that we run a very efficient center without delaying anybody. And one thing that I learned is that parallel processing, which is what, you know, we incorporated a lot in at the West Side, is where we do the blocks while they open, while they set up the case. It learned to be very crucial to make sure that we're not delaying anybody. It also keeps the room moving very efficiently. Our turnover times have reduced substantially. It used to be about 25 minutes. We're down to like 10 to 15 minutes per case. So that's one thing that I noticed. And our volume has you know, it was a 2 OR run surgery center. Now it's a 3 OR run surgery center. Our volume expanded from 2,000 cases a year. Now we're up to almost 4,000 cases a year. And I would say about 60–70% of that incorporates regional in every case.
That is great. Now, next on my screen is Dr. Warlick. If you could go ahead, introduce yourself.
Hi, everybody. I am Alicia Warlick. I'm the director of regional anesthesia in a large practice in Raleigh, and I'm on the phone because there's a powder outage, so I'm sorry that you can't see me. But I work in 3 separate hospitals, a level 1 trauma center, and then a secondary hospital, about 300 beds, and then a little ASC type hospital. And a recent win I had was we started a hip fracture protocol a couple years ago. We incorporated the PENG block using one-shot block system. We're catheter free in my system. And so we involved the education of the ED doctors, and you know, it was a big hospital-wide push. So we had to do nursing education, and we've successfully blocked and put about 2,000 patients through this hip fracture protocol, wildly reducing opioids and changing sort of the course of how we do hip fracture. So that was one of my wins, and we're doing great.
Fantastic. Next on my screen then is Dr. Norenberg.
Hi, everybody. I'm Jennifer Nornberg. I practice out in San Diego. I work for Kaiser Permanente, and I'm kind of the cautionary tale. I work for a large group of over 70 anesthesiologists that cover 3 hospitals and 3 surgery centers. And we have not successfully maintained a pain service or block service. So currently we do work with the surgeons on doing single shot blocks of several different varieties. And we do employ Exparel. We did have a catheter program for a little while, but follow-up became very difficult. So I have plenty of suggestions of what you can do with limited support resources. So I will be happy to share any of those with you. They may be little wins, but they still exist.
All right. And then last but not least, we have Dr. Herman.
Hi, good evening, everyone. I'm Dr. Melody Herman. I'm the Director of Regional Anesthesia at Carolinas Medical Center in Charlotte, North Carolina. And our program, I think, is unique in that we're a private practice, so we don't have an anesthesiology residency, but we're also a level 1 trauma hospital. We're the county hospital. And we're the only level 1 in the region. So when I started with CMC back in early 2021, we were doing some blocks, like maybe 50 to 100 a month. And then from there, we really ramped it up. It was a group effort. It was a team effort. Resources was a major contributor to our growth. So now we do about 300 blocks a month. When we first started, the expectation was you're going to cover 4 ORs, potentially 2 to 4. And then you're also do as many blocks as you can, both perioperative and consults, rib fractures, things like that. So leaving, the OR to complete those, which is, that was impossible. So we've grown a lot. We now have a PA. We didn't have that before. She rounds on our catheter patients and writes the notes. We have 2 block nurses. We had no block nurses when I started. You had to just find a friend to help you. So now we have 2 block nurses. We feel very blessed for that. We started out with 2 ultrasound machines. We now have 5. So the growth is really, rewarding to see, and we're still growing. I would say a recent win for us would be that we don't have the ability at present to do acute pain medication management. But I went to the recent Azure Spring meeting, and one of the great things about going to these meetings is you meet so many people from all over, and you network and you get new ideas. So I reached out to Ed Mariano at Stanford, Raj Gupta at Vanderbilt, Bridget Poulos at Mayo Clinic, just for some ideas on Jerry Jones at University of Tennessee, Nadia Hernandez, Memorial Hermann, on ideas of for a document on acute pain medication management for perioperative pain and trauma that we could just kind of give to the surgeons as a reference to kind of guide them without us actually being consulted, because again, we don't have residents. Our service has more like banking hours, not a 24/7 service. So I'd say a big recent win is working on that.
That is great. Okay, so no questions yet, but while we're waiting for all of you to finish typing in your question, Dr. Herman, real quick, so when you went from 0 nurses to now, kind of a thriving practice, that took fiscal resources. And so when you went to hospital administration, what did you go to them with to, kind of convince them that this was something that needed to happen and was, presumably fiscally in their best interest?
Length of stay reduction. Again, because we are the county hospital, a lot of our patients are uninsured or underinsured. And so, yes, do we bill for the blocks? Yes. But the length of stay reduction is really where the cost savings is for the hospital. And we were able to demonstrate that. We have a list. We have several different lists. We have lists where, where the patient was in the hospital only for pain, and we do a block or a catheter typically, and then they leave. And then we have a statistician that works, the group I'm with is Scope Anesthesia. We're contracted to work with Atrium Health in Charlotte. And so we have a statistician that he's amazing, that works for us. And he pulled data on a few different service lines. So our minimally invasive thoracic cases, and then our rib fracture case consults, and also ankle fractures, and pulled data, tried to ASA match and match like type of injury, things like that. And, the length of stay reduction was profound. So we took that data and presented it to the hospital, and, just basically the proof is in the pudding, like our results make the noise. So with that, we've gotten 2 more block nurses. And then we just recently got 2 new ultrasound machines. So I think that, that was really impactful when we were going to hospital administration and asking for resources.
For sure. Yeah. Building a team to do any of these things is absolutely essential. I mean, I definitely feel it on the weekend when we don't have our block nurses available, versus during the week when we do. Not having them there all the time would certainly be a challenge. Have any of the other panelists, any techniques or approaches that you've used with administration to obtain funding for either personnel or equipment that you have found to be successful? Especially you, Dr. Kim, who's had to navigate this across multiple different hospitals then within the HSS system.
So for us, ultrasound has been something that we know that we need to acquire. We needed to. For us, it's actually very easy to make the point about how effective the blocks will be as far as PACU discharge. If we do the blocks, the PACU discharge will be much shorter. So it's a very cost-effective way of promoting regional. And I have to say, like the surgeons that we have at HSS are very pro-regional. So it wasn't too hard to get, a couple of ultrasounds for just 2 rooms. And for the most part, most of our surgeons kind of grew up in that environment. They all came from HSS. So they were kind of acclimated to expecting blocks with all their cases. Now, what I have done though is that there are newer blocks that we try to incorporate more. Someone mentioned the pain block. We actually use the pain block with a supraglenoid fascial lockup blocks for our hip scopes. And one thing that we did is we looked at data, and we looked over 300 patients, and we found that we did, decrease discharge times by 90 minutes, which is substantial for a high volume center. So by showing it to them, not only do they appreciate it, but they recognize how effective the blocks are, beneficial for them.
Fantastic. Yeah. I mean, talking about Peng here, then Dr. Warlick, so when you went and talked to your surgeons, about this block, presumably, you'd seen some publication, you'd gone to a conference, you'd heard about, how great it is and how helpful it is. But like, what was your conversation with the surgeons like then to, kind of get them on board with offering this procedure to their patients?
So this is something that I learned from Nigel.
Can you guys hear me?
Yep.
Yes.
Okay. You're asking me, right, Alicia? You're asking me?
Yep.
Okay. Yeah, that was an interesting question. Some of the surgeons really didn't want to be involved. And some of them even asked for us not to block their hip fracture patients at the beginning. And so I had to sort of take a step back and realize that they needed more information. So what I did was I presented at their meeting, at their conference, like one of their board meetings, and I presented the AAOS data, their guidelines for hip fracture, geriatric hip fracture. And one of the guidelines, of course, is like a 4-star recommendation for regional anesthesia. And so I didn't really give them a choice. I said that these are part of your guidelines. They're what's best for the patient. And we're considering the overall opioid reduction strategies of the hospital here. So we're going to go ahead and do this. We need your support here because this is for our patients, your patients, in the best interest of them. So after I presented all the data, I showed them the technique. I actually went over images of the PANG and how it differs from femoral nerve block and how it's motor sparing so that we can do the PT post-op day 0 and 1. And so they understood it. So it took education is what it took for me to explain to them why we needed to do this, why it was in their best interest to wait. You know, some of them had problems like, you know, the old saying like, hey, it's taking too long. Like, I don't want that. Just don't block my patients. And so I explained to them why that wouldn't be acceptable, you know, for our geriatric hip fracture population. And so I totally got them on board. And in fact, some of the naysayers afterwards like demanded it. And some of them even now, this has been 2 years in, they asked me to, well, we had a couple transition for like new doctors coming in, and some of them asked like, hey, can we get that person on board right away for doing our blocks? Because they notice a complete difference in the patients that maybe don't get it, or they get like missed, you know, somehow. And so they're like, they demand it now. So it's come full circle where I was convincing them that this is the best thing to do. And now they are fully on board and wanting me to present this data to like their national societies. So I'll be going, you know, to some of these meetings and presenting what we created here. They're very proud of it. In fact, they try to pawn it off as their own, but they're always reminded by my partners that we came up with it. I don't care who comes up with it, as long as the patients are happy and they're getting the care they deserve.
Having a physician champion is absolutely outstanding. Dr. Kim, you were going to add something as well?
No, I mean, pretty much, you know, Nigel Sherrick was the guy who brought regional to HSS. I mean, his reputation, he's legendary. And the one thing that he taught everyone here is that you do have to have a buy-in with the surgeons. You have to make sure that you understand what you're doing and why you're doing it. And it's to their benefit too. And one thing that is very important for us is to always present the data. So whenever we do introduce a new block, we do make sure that we prove that one is very safe, and two, it actually does provide the outcome that we're all looking for. You know, whether it be PACU discharges, whether it be pain control, opioid reduction, something that we can all agree on. Then once you show that, you know, with the data that all these things kind of line up, they're more of an agreement. It's more of a collaboration, you know, at HSS when we have the surgeon support to do these blocks, is we have to make them believe that they're a part of the process too. And it's something that I kind of appreciate and I kind of learned, you know, at HSS, that when you have it is their patients. And once you have them understand that, you know, we're doing it for them, you know, as well, that they'll be more receptive to do these blocks.
Yeah, that is great. Okay, so I am going to get to our viewer questions here, which they are pouring in. Thank you so much. So Jerry Jones had a question about how to gain more surgeon support and do more blocks and help convince administration to get on board. And I think you guys have done a great job of answering that. But Dr. Fayez Ahmed said that wrote in that he has a couple questions. So he's working on expanding the regional services and working with different surgical services and perioperative services as well. But he has found it difficult or challenging to convince the surgical team that fascial plane blocks might be beneficial for their patients, specifically for thoracic and abdominal procedures. And so, you know, do you have any advice there, you know, especially when sometimes our fascial plane blocks, you know, if our main discussion point with surgeons, you know, is going to be using data, especially for some of these where maybe data might be either limited or mixed, you know, how do you then kind of talk to your surgical colleagues in those situations and kind of try to move them toward incorporating more of these fascial plane techniques? Dr. Norenberg, I don't think we've heard from you yet, so would you maybe be able to offer some advice there?
Possibly. So basically for us, our challenge is Kaiser's very different. We're not motivated by reimbursement because we are self-insured. So most of the time when we are trying to get something passed and communicated, it really does come from an experiential status. Somebody comes back from a meeting and they're like, let's try this. Let's work on a new protocol, or, you know, I've noticed my patients are having a lot of pain. What else can we do? So everything in our world kind of moves slowly. As far as fascial plane blocks go specifically, Our breast surgeons, especially our plastics breast surgeons, are big fans of. Sorry, guys, I'm still at the hospital. And so it is a regular discussion with them, and we've introduced with them the idea of the ESPs. Some of them are interested in it. Most of them are still on the PECs, which variably works. And then oftentimes we will share, and this is actually answer a question from above about the catheter program from Patrick Emilife. I don't know if I'm pronouncing that right. I'm so sorry. But anyway, so they use Exparel to supplement our blocks. Some of them will do fascial plane blocks intraoperatively, like tap plane blocks, and then they will work some Exparel in there. Our colorectal surgeons will do a rectal block. Our podiatrists will do their own blocks using Exparel. We do not use Exparel in our blocks. We are pretty much only doing plain bupivacaine blocks because our trouble is because we're not motivated by reimbursement, length of stay does not necessarily have the same impact as other institutions may have that are regularly receiving that as feedback to help them make ends meet. And so for us, it really just, again, comes from that experiential part of, oh, maybe this will be better for the patients or other things like that. So our catheter program and our any of the long-term block follow-up, we do not have any staff available to do that on a regular basis. So we use typically 0.25% bupivacaine because we can predictably tell patients about how long it will take. And we actually still lean very heavily on multimodal oral medications for them postoperatively, NSAID, Tylenol scheduled, gabapentin oftentimes at night to help the patient sleep. And then we still use quite a bit of opioids postoperatively as well. So we are a very different, still maybe a little bit more, not necessarily on the edge of technology. But we do a lot of single shot blocks. We do them for all of our shoulders. We have a very robust hip fracture program with a single shot block, typically within 12 hours before their surgery to help with pain control. We typically are doing a lot of blocks for our foot and ankle surgeons, doing robust blocks for our vascular surgeons for AV fistulas. We do QLs for our nephrectomies. So we definitely do a lot of single shot blocks, but because of the limitations of our follow-up, we have to be very thoughtful about what we choose for our medications and the safety margin for our patients. And that's more the focus than necessarily the length of stay reduction, or trying to push for additional funding to have more support. So that's where we're at. Hopefully that helps.
Yeah. Any of our other panelists, any advice on incorporating, either abdominal or thoracic fascial plane blocks into their practice?
One of the issues we had when we started expanding fascial plane blocks for thoracoabdominal analgesia was this expectation that a block for the chest wall or abdominal wall is going to be the same as a brachial plexus block or a femoral or sciatic. Like everything's going to be numb. And so early on, we're doing, serratus for chest wall or, a QL for a nephrectomy or cystectomy ileoconduit. And then they're coming out into recovery and they're having some pain. And the calls we're getting from the recovery nurses that the block didn't work. And then so there's some education there, like, well, this is part of multimodal. It's not going to be as dense as an extremity block. But when we look back at our data, it is helpful. So I think education was huge when we first started rolling out fascial plane blocks in our program.
Have any of you encountered, surgeons wanting to do their own, blind tap blocks or things like that? And just, kind of the, in my experience, decreased quality regional anesthesia associated with those blind blocks. I mean, I think we used to operate a long time ago on pops and clicks and sort of found that was sort of not the ideal way to sort of operate in these situations. But I don't know. Have any of you encountered that, and like any approaches to maybe making that situation a little better, Dr. Nordberg?
Actually, the few surgeons who do their own blocks actually do very good for us. So they've gone and they've gotten training for it, and that's why they request to do it. So our surgeons who do breast procedures who want to do their own blocks, the patients are very comfortable. The same thing with the few surgeons who do their intraoperative taps. They do it under direct visualization using the laparoscope or the robot. So they're not doing it with pops and clicks. They are actually watching for the correct spread, maybe not under ultrasound guidance, but no, my experience with the surgeons who have expressed interest in doing their own blocks, at least at our institution, they actually work. So it is possible.
All right, so
Sorry.
we have some other questions here. It looks like Dr. Daniel Shams wrote that Dr. Herman spoke at ASRA about incorporation of nerve catheters and blocks in orthopedic trauma, and was wondering if she or others could expand a bit on the process of surgeon buy-in with that specific patient population.
Yeah, so when we first started blocking for ortho trauma, there was really just one orthopedic surgeon that was on board out of a group of 6. One, Dr. Joe Shu, and the others like had some like variable, ideas about different types of blocks, but really like the only one that consistently was just like block everyone, acute tibial plateau, everyone, was Dr. Joe Shu. And so, and we did, and the patients were comfortable and were ultimately leaving the hospital sooner, and they weren't developing a compartment syndrome that was masked by a regional anesthetic. So again, we don't have an anesthesia residency to do like frequent checks on these patients, but there is an orthopedic surgery residency, and the residents are very good about follow-up afterwards, and there's robust post-operative surveillance for these patients. And so you looked at Dr. Joe Shu's patients, and they're getting blocks for their acute tibial plateaus, and they're not developing compartment syndrome. And we've done hundreds of them. It's such a rare event that to power a study to demonstrate this, you would probably need hundreds of thousands of patients. We have hundreds, eventually maybe thousands, and we're just we're not seeing it we're not seeing this monster under the bed kind of complication develop with regional anesthesia and compartment syndrome. So I think that when other surgeons saw that, then we were getting buy-in from some other orthopedic surgeons for our tibial plateaus and our femoral shaft fractures. We do use dilute local anesthetic, and not all the surgeons are on board. I would say probably about half of them. And then the other half, it's a risk benefit, want to talk about it. And there are some that just, really prefer that we don't block those patients, and we don't push. I mean, we have a lot of business to go around. And again, our results make the noise. So, we just wait for them to come around, and, when it's the right patient, the right time, we're happy to block anyone.
Yeah, Dr. Warlick, then, you kind of talked about, incorporating PANGs into hip fractures, hip patients with hip fractures. Was that something that you were able to protocolize, or do you reach out to the surgeons on an individual basis, and find out, gosh, boy, this patient's okay, this one's not, or is that something that has been well established here ahead of time? And then how did you do that?
So what we did was, I'm really lucky to have a dashboard system to collect different metrics. And so we looked at what we wanted to add to our ERAS protocol. So I did it by actually creating an ERAS protocol. It's kind of how I sold it. And we started gathering the metrics. And it was sort of a gateway drug into the trauma world, because a lot of the trauma surgeons are not regional friendly. But I thought this was a really good item to add to their to our list of offerings for them for trauma. So created an ERAS protocol. I named it hip fracture protocol. I actually looked up all the codes of the patients that would be included in the hip fracture protocol. So all the different kinds of fractures. that would get a PENG block. So in concert with the administration, and the surgeon on the committee. So I had a surgeon on the committee, an internal medicine head, an ER doctor, and me on this the committee. And so we decided which fractures we're going to block, and that the trauma surgeons agreed to these fractures and that it would be okay. And so we included it in our ERAS protocol. And so then we wrote the protocol. I rolled it out to my partners, and then I started training a few of them, some regionalists on my team, and then some non-regionalists like cardiac and peds people that were not quite as interested. But in my group, we all have to do the blocks, at least the basic ones, proficiently, even in the middle of the night. So I trained my group, and then eventually the gospel spread. You know, everybody wanted to do it, and it sort of became a cool thing to do. And eventually we had buy-in, and now we're blocking up to 89%. I think this month was like we're blocking 89% of these hip fractures. So big success story. Very proud of the cooperation I got from all departments, and it's pretty fun.
And then, as a part of that, have you brought in your emergency medicine colleagues to also be a part of performing some of those blocks? I know just, for us, sometimes these things occur at a time where we just don't really necessarily have the staffing to go down to the emergency department to do these things. Is that something that you've been able to do, or have you used that for other procedures?
No, I actually, we have a 2-block system. So when the patient hits the ER and they get an X-ray, that's what we name time 0 when they diagnose the fracture. And the ER, my ER colleagues are placing a fasciolaco or a femoral nerve block at that time. And so we've reduced opioids from the ER to the pre-op area, which is in my system could be like 10 to 15 hours, maybe. It's under 24 hours by the time they get to surgery. So we've reduced opioids by like 70% in the ER in that transition. And then we place a PENG block using long-acting bupivacaine in our pre-op area, extending, the rest of the stay. So they actually have learned the fasciolaco block. I trained them. Some of them don't like the femoral nerve block, so I've given them 2 options. You can place a femoral nerve block or a sci-fi block, or just regular fasciolaco just to help with the pain. And just yesterday, I was in the ER, or this weekend, I was on call on Sunday, and I went up to like a 90-year-old lady up in the ER. I went to go see her. She was about 3 hours into the stay, or maybe like 5 hours. And I said, "Hey, they did that block for you. How did you like it?" And she said, "It took my pain away from a 10 to a 1. And, she really recognized the power of that first initial block. And I just thought, wow, this is exactly what this protocol is made for. So just the whole system has worked out just great for our particular hospitals. And everybody's really proud of the work we've done, especially the ER physicians didn't think it could be done. And we've shown the hospital that we've done great work with it.
That's awesome. I know there's a German study where they actually even trained EMS providers to perform fasciolaco blocks kind of at the scene, before even trying to, transport these people into the hospital. Dr. Norberg, I saw that you were waving your hand.
No, just waving at somebody leaving because I'm still running the floor. Sorry.
All right. Dr. Kim, I was, one of the things here that I think, oftentimes can be really helpful for us is data, right? And so not just data to propose doing these blocks, but data to propose continuing to do these blocks, or, maybe thinking about considering doing something different, whether it's multimodal or a different block or no block. How are you able to leverage data collection in a large system like HSS, to kind of support the regional anesthesia that you do there?
So that's a good question. So one of the things that we've done, I guess a good example would be like for our total knee replacements. We first incorporated like the femoral nerve block. We showed that the data was very effective, especially when you compare it to something for pain control. But then, as ambulation became a very key component of ARIS and getting them out, and now same-day surgery, you're not going to incorporate a femoral nerve block anymore. So what we did is we did RCTs, we did retrospective studies, prospective studies, and we showed that the data with the Dr. Canal blocks with IPAC blocks, and now the Dr. Canal blocks with IPEC and genicular nerve blocks seem to be very effective controlling the pain afterwards. And these are all motor sparing blocks. So these patients are up and about on post-op day 0, clearing PT and going home the same day. And when we show this data to the surgeons, not only it comes down to how they talk to the patients in the recovery room. They're one of the first people that talk to the patients in the recovery room. They see how grateful the patients are and how well they do afterwards. They talk to the physical therapist as well, and they notice which patients are doing very well afterwards, and usually are the ones that get these blocks. We actually did a study pretty recently where we're comparing periarticular injections compared to our motor sparing blocks. And we noticed that there was not that much difference as far as opiate consumption, as far as pain control. So it kind of proved that one thing that we can do, and this was just with 2 blocks, we didn't incorporate the genicular blocks until last couple of years. And right now we're actually doing RCT right now, but I guess I only talk about anecdotal, but we noticed that the surgeons are actually telling us they notice a huge difference. Not just on post-op day 0, but also on post-op day 1. Like these patients are telling them they're not taking those pain medication, they're very satisfied, and they're at home. So something that they all wanted to achieve within the next like 2-3 years as they transition their joints over to ambulatory centers. So that's one thing of where we can see how data-driven studies kind of helped guide our protocols and also guide the surgeons to know that what we're doing actually is correct.
Yeah. And I think, if you are doing that kind of research in one of your places, even if you're doing it as a QI project, if you found something that you don't see that, has been published elsewhere or doesn't seem to be part of, the common lexicon, get it out there, submit it as an abstract to ASRA or ASA or something like that. Don't keep that stuff hidden. And some of these QI projects too, if you're part of the MOCA process, that's something that you can use as well for that. All right, Dr. Herman, Dr. Korn has a question about possible nerve injury in some of these trauma patients. How do you, maybe assess these patients beforehand? How do you document it? How do you determine, in these patients where a neurologic exam might be difficult, what you're going to offer then for regional anesthesia in that setting?
So with trauma patients, if there's a pre-existing nerve injury or nerve injury from the trauma, it's a discussion with the surgeon and then a discussion with the patient, and then we go from there. So I'll talk to the surgeon, see, what my thoughts are on offering the block, what their thoughts are on offering the block. And then if we're on the same page for offering a block, then I'll go to the patient and I'll do my own neuro exam. And there'll be some discussion of this is what a block is, this is how long it lasts. It's not going to make this pre-existing nerve injury worse, but your extremity will be numb for, however duration of time, depending on what sort of block we're doing and what sort of local anesthetic we're using. And then I leave the choice to the patient, whether or not they want to proceed with a block. So it's, a discussion with all of those people, and then just documenting clearly in my regional anesthesia note, what blocks we did, and if there was a nerve injury, what it was, and what was the distribution. And I feel very fortunate that we have a really good relationship with our surgeons. I know that's not the case everywhere, but there's not so much throwing under the bus for these sorts of things at my institution. And so I think that we're really fortunate in that way. But discussion with the surgeon, discussion with the patient, and very clear documentation.
That's great. Okay, so next question that we have is a question about block timing. And oftentimes surgeons being concerned about our blocks delaying their procedures. I've personally never done that, but I hear maybe other people have. And them trying to push these things to post-op, where especially if these are cases that are going to be done at the end of the day, where our ability to attend to them, might be more limited by nurses going home and our faculty wanting to go home at the end of the day as well. How do you have these discussions with surgeons about maybe some of the benefits associated with doing these blocks ahead of time, where we could limit intraoperative opioids and all that sort of thing, but also just some of the realistic logistical issues associated with, doing it beforehand versus afterward. I don't know, Dr. Warlick, do you have any thoughts on that?
Yeah, I do actually. We had a while there where we set up our block program, and once again, I started with no block nurses, so I was sort of like asking a friend, like Dr. Herman was, to gather all the materials. It was sketchy, and so once we established our block nursing programs and we got a block area, and that took about a couple years. Then we had these outlier surgeons that would post a lot of cases, be very busy. One of the trauma surgeons we used to block for ankle fractures. And as the day got longer and things got delayed, he would say, no more blocks for the rest of the day. These last 4, we're not blocking those. And I, went to talk to him many times and said, hey, this is just how we're going to do it. We're going to block. I'll block them for you. Like, I'll get you through it. But it kept happening. And so I made a policy in our system that we don't do blocks in PACU, only in absolute emergencies, because we were finding also that there was a safety issue too, that the block nurses in PACU didn't know about LAST, or they didn't have LAST training, or, we didn't have the supplies. So it would be like 4 trips to the pre-op to get the ultrasound. So it was a systems and safety issue to perform blocks in the PACU. And, the surgeon that was asking thought it was just this casual thing, like, go ahead and just do it in the PACU, no big deal. So I had to have a meeting with most of the surgeons telling them our new policy and the reasons behind it. And so that guy stopped asking for us to just blow off the rest of his blocks and just do them whenever we had a chance to. So after making that like no block in PACU policy, only in emergencies, we got everybody on board, and we said, this is not just, we're not providing, we have to provide the same level of analgesia to these patients. And this is the anesthetic, right? Like, these ankle blocks are sciatic and saphenous blocks for ankle trauma. That's the anesthetic most times. And so our opioid consumption is way over. So I showed them the dashboard, I showed them the NMEs that we were using. And so that's, once again, going back to the data and showing them and talking about safety and systems and what is appropriate for our system, was not having the anesthesiologist just find them in the PACU when they're screaming in pain. That wasn't appropriate. So I just made it a policy, and it worked.
There. Okay. Let's see. So it has to block their. Oh, interesting. Okay. So there is a question here where surgeons have asked the people in this institution to block their patients before arriving to the operating room with no sedation, which some people don't use anyways, to avoid delaying rolling back to the operating room. I guess, what are your thoughts about maybe routinely doing blocks without sedation, maybe to facilitate, the surgeons, not totally clear, but maybe to facilitate the surgeon's need to, finalize any question answering or anything like that. My usual thing is to give people midazolam and fentanyl, but I think a lot of the times what we do, wouldn't necessarily require it. I don't know. Do you guys have any thoughts about the use of a different sedation policy to facilitate surgeon workflow?
So we don't, because we have 2 block nurses and we're really busy. I mean, we may have, 5 first case blocks, and with that many and patient getting ready, ready in the pre-op area at 6:15, and then the expectation is 6:45 you're going to start rolling back to the OR for 7 a.m. In room time. We don't have those 2 block nurses every single day. So many of our patients don't get sedation for that reason, just because we can't, if I only have 1 block nurse that day, I can't, and I say her because both of them are female, but I can't leave her with that patient and then, the other ones don't get blocked. So we do use subcutaneous lidocaine skin, things like that to, try to eh, optimize the comfort. And again, these are trauma patients. So it's not like a patient that, came in and they're getting this elective thing done. They're already hurting. And so I think that they're more amenable. It's almost like when you're in labor getting an epidural, like you're ready. Like you just want pain relief. But really just from a resources perspective, many of our patients don't get sedation for their blocks.
Yeah, I think that's very reasonable. The needles that we use, they're smaller than what we use for IV catheters. I think, in the past where maybe, we weren't using ultrasound to identify these targets. These are things that might have been more uncomfortable. But now, if it's a shallow block, you anesthetize the skin well, it doesn't seem terribly unreasonable. Dr. Al-Saidi did ask a question that kind of goes along with this as well. After you've performed a regional anesthesia procedure, how often or for what duration then would you generally monitor these patients for signs of last or maybe excess sedation if you had been giving that? Dr. Kim?
So, we do sometimes do blocks in the holding area, or in the PACU as rescue blocks. And usually, last doesn't manifest itself, when it does happen, there is, one thing that I guess you could say is like, we don't, um, we don't have like a firm time set of how long do we keep the patients for in the PACU before we send them home. But most of the time, I would say like most of our patients stay in the PACU at most, maybe earliest is 30 minutes, after a block is done. But it's really, if last were to happen, it would manifest itself pretty quickly, especially if it's um, I don't know if you use epinephrine anymore, but if it manifests itself either with vital signs or with patient symptoms like ringing in the ears, you once it hits the bloodstream, you would know pretty quickly.
Yeah, I know in our practice, we generally like to try to monitor people for 30 to 45 minutes. Unfortunately, with how busy we are in the morning, that doesn't necessarily mean somebody stays at the bedside for that long. That means though that they are, continuously hooked up to monitors for which there would be external alarms if there were to be some sort of change in hemodynamics. Oftentimes though, these blocks, especially in the morning or even throughout the day, they're left with, their family member as well, and they're given instructions about how to contact help if they were to need it. They're given the call light and shown how to use that. Our time is drawing a little short, and one of the things that I was hoping to get from each of you is kind of an idea about the future, right? So, where you think we're going next, what is something that we should be aiming for, and maybe how you're kind of positioning yourself to get to that target. So again, it's just the way that you're organized on my screen. Dr. Kim, I'll start with you.
Sorry, can you repeat the question? I'm sorry.
Oh, yeah, just where do you, just kind of future considerations, what do you think our next block target should be? How should we get there? Is it not a block? I guess it could be a new medication, even that you think that we should be introducing. It could be a new procedure, whether it's, peripheral nerve stimulation or cryo or something like that.
Exactly. That's actually something that we're actually looking at, neuromodulation. I think that our outcomes, we're pretty much, settled on like the 2-3 days post-op pain control, but we have to look further out. We have to look at the 3 months, 6 months recovery period and see how we can help them, as you mentioned, with neuromodulation.
And I guess a question with neuromodulation, we've kind of looked into some of these things within our institution, and a lot of the problems that we've been encountering are problems associated with insurance reimbursement. And for those reasons, it's really been something that has been basically a wall that's made it so that, this is just something that we are not able to offer at this time. And so I don't know, have you discovered any ways to get around that?
So I think it's like I think what we do is that as the data comes in, as more studies are done, the insurance companies may eventually get reimburse these things. So it's important for us to, we're actually looking at funding right now, looking at different grants. I'm working with an orthopedic surgeon right now, looking at ways of funding projects and studies with cryo, but also, the peripheral nerve stimulation devices as well, working with our colleagues in chronic pain. It's one of those things that I think reimbursement is important, of course, but we have to prove to the insurance companies that these things do matter. And the way you do that is with studies.
Yeah. Dr. Warlick, same question.
Yes. You guys can hear me, right?
Sorry.
Are you
Yes.
there?
I was giving you a thumbs up, but
Okay.
then totally forgot that you don't have
I'm on
video.
the phone. Okay, two things that I'm really excited about recently. I think that POCUS has really made me a better anesthesiologist. Being a non-cardiac person, I don't have easy access to echo. And I think that the gastric ultrasound and all the POCUS stuff I've learned at ASRA actually has really made me a very, very good, improved my skills just to be overall just a good doctor and diagnosing things and getting people through through crunches that they get into in the operating room and in the PACU. And so I love that. But we're also looking into cryo too. Some of our surgeons are interested, and sort of how that fits into our busy practice, where we are a bit focused on timing and reimbursement.
I totally agree that POCUS is a huge opportunity for us, an opportunity for us to lead our groups. We are generally the ones within our groups that always has the ultrasound probe in our hand. And, what we've tried to do is try to make it so that, gosh, every time we do a spinal on some guy and then we're waiting for them to take him back to the operating room, just ask him, hey, do you mind if while we're sitting here and none of us have anything else to do, if we go ahead and just look at your heart real quick? And I have to say, in general, more often than not, these people are really excited to kind of contribute to our learning, which is just really, really kind of fun. All right, Dr. Norberg, same question about future practices.
Ooh, that's a fun question. I have a couple of things that I'm really excited about. One of them is one of the things that that drives our practice is the quality metrics, less so from a reimbursement standpoint, more from a recognition standpoint. So we've been doing a ton of work expanding ERAS amongst all of our surgical services and pediatrics as well, and included our C-sections. And we've been making a ton of progress in that. And we've been working with our surgical services to really optimize for our particular practice what works from a multimodal standpoint, as well as working in regional wherever we can. The other thing that we are working on, and is something that I'm really excited about, that ASRA also supports, is some of the integrative practices. So I know that HSS, Stephanie Chang, is working very hard on CME certification for auricular acupuncture that helps with pain, nausea, and anxiety. And so that's something that I'm hoping to bring to our practice, because in the state of California, if you have an MD, you should be able to be recognized to perform auricular acupuncture, as well as some of the other nutrition aspects, because we have a long waiting period for our orthopedic total joints. So really trying to do a lot more prehabilitation. So while it's not specific to a regional practice, it is something that is on the horizon as far as making us better perioperative pain physicians. So I'm excited about that.
Oh, that is great. I think anything that can kind of increase our scope beyond just the immediate perioperative period is great. And especially with so many of our patients being orthopedic patients, anything you can do to increase their strength and mobility before surgery certainly will pay dividends afterward. All right. And then finally, Dr. Herman, same question about our future.
I would agree with Dr. Warlick. Point of care ultrasound. It's eye-opening what you'll see when you put a probe on someone's chest, and it's definitely changed my practice. Or gastric scanning. I remember I took the ASRA POCUS course back in 2022 in the spring, and I went to the course with a colleague. We both came back that weekend or the following weekend, we were happened to be on call together. And I had a patient that was a rib fracture patient, left-sided rib fractures for a rib plating, get the double lumen in, and then the patient just becomes hypotensive. And so I have a probe right there, and I put it on the chest, on the left chest, and I saw a lung point that you see the clear sliding and then absence of sliding. Told the surgeon, he came in, put a chest tube, they got better. And just countless stories of these patients, these high acuity patients, where you can get the answers you need to diagnose and treat much quicker with an ultrasound, which you already have with you if you're a regionalist. And the transition from learning regional anesthesia to POCUS is so it's not a big leap, but you already know how to use an ultrasound. It's almost like when I teach my cardiac anesthesia colleagues how to learn blocks, they're already facile with ultrasound for lines and TEE and things like that. And so they pick it up really quickly. And the reverse is true also when you're if you're interested in POCUS. I definitely encourage anyone with an interest to learn it, because it's fantastic, and I think the future for anesthesia.
Well, and I also attended one of the ASRA POCUS courses, and I have to tell you, it was absolutely phenomenal. And anyone listening, if you were at all thinking about this, there is an ASRA POCUS course coming up in Nashville, Tennessee, September 14th through the 15th. Registration has not yet opened for that, but it will soon, and I would strongly encourage you to consider attending. We have had a question about how people could follow you on the various socials. So in the same order, I don't want to announce you again, but if you could just go through and just kind of let people know how they can follow you on Twitter or X.
I actually don't have a Twitter account. I'm not on X either. So.
All right. How about you, Dr. Warlick?
I'm on all platforms. I'm Allie Fit MD. I'm also a personal trainer, so that's the fit part. But I also run ASRA social media. You'll see me on there talking about everything POCUS, ASRA. So I'm on the ASRA socials as well.
Dr. Nornberg?
I am Dr. Jenny, Jeni, MD, on both Instagram and on X. So easy to find.
And then Dr. Herman.
Yep. I'm Anesthesia Doc MD. With regional anesthesia content, I'm most active on Twitter. I have an Instagram too, but Twitter is where I post most of my regional anesthesia and POCUS content.
All right. And we are drawing to an end here. I really want to thank everyone for attending. I want to thank this panel. This has been awesome. Thank you so very much. This was incredibly helpful for me. I know there are things that I will take back to my practice and incorporate tomorrow. Last thing, please remember that registration for the 23rd annual pain medicine meeting in Las Vegas, November 21st through the 23rd is coming up. Abstract submission opens very soon, April 25th. I know I am excited to go there. Las Vegas is just a little bit of fun. This concludes today's program. Thank you all so very much, and have a pleasant evening.